Emma, am I okay to go?
Yes, you're
Okay,
live.
great. Well, welcome everybody to the next seminar in the Lancet Commission on Gender and Global Health series. And I'm delighted to welcome you wherever you are in the world. Today marks 1 year since we launched the Lancet Commission. And so with your permission, I'm going to take an extra few minutes of your time before we move to our main speaker. I know that most of you will have actually tuned in to listen to Gary Barker, so forgive me for taking advantage of having you all here, but I'm just going to take a few minutes to reflect back on the amazing work that has already been underway over the past year, and in particular the seminars that you've all already had an opportunity to participate in and listen to. So let me move to my slides, hoping that technology is working in my favor here, and just reflecting again that it's a year ago today that we published our introduction to what we hoped that the Lancet Commission would be achieving over the coming years of work. You don't need me to remind anybody listening to this seminar that it's been an extraordinary year in which to be trying to run a global commission. Even for those of us involved in public health as our bread and butter daily activities, I don't think that a year ago any of us would have predicted that as a commission we still have not had an opportunity to meet together. Which has been a huge loss as far as our ability to interact with each other is at a personal level is concerned, but I think has really opened up the space for thinking about new ways of communicating, not just with each other, but with everybody listening to this seminar. So just this slide is just a really quick reminder that we set up the commission with a number of core principles, that the work that we were going to do would be based around an understanding of the politics of gender and global health, something that we've heard time and again throughout the seminars is absolutely central to not only why we might not have moved forward in a way that we wanted in the past, but understanding the politics will help us move forward in the future. We set ourselves up as being explicitly feminist, globally relevant, rights-based, inclusive, and intersectional. And for those of you that have been able to tune into more than one seminar, you'll have very much realized that our approach has been both multidisciplinary and to some extent multi-sectoral. We explicitly wanted to move away from the echo chamber of gender experts just talking to other gender experts and have a combination of both gender experts and subject experts. We very much want to engage with the wider community out there, of which this seminar series is part of our aim of engaging in a dialogue with people, not just disseminating the knowledge that we find through the Commission. And again, that speaks to a vision of the role of the Commission and the work of the Commission about incorporating a vision and voices from the ground up and from top down. We've set up a structure of the Commission that involves relationships between the co-chairs, the commissioners, the secretariat, who are the people who set up and organize and really run this incredible seminar series that you're all listening to. Fellows and contributors across the range of institutions and organisations that the commissioners are housed within, and of course our colleagues at the Lancet who act as the sort of lightning rod to make sure that they're keeping us all on track, and that we're trying as much as possible to keep to timelines, as well as the intellectual energy that the Lancet of course brings to the work of the Commission. So this slide just sort of is a quick reminder of the global spread of the commissioners. The little pictures that you see, you probably can't see any of us in full detail there, but each picture represents the geographical location of a commissioner. But the slide with the map with the purple color on it just indicates the countries that commissioners actually work in or have expertise in. So although we might be confined to one country each at the moment, and we certainly are in pandemic times, the experience and the networks that we bring to the Commission are much wider than just the 20 odd countries that we currently all live and work in. One of the things that we have been really keen to do as a commission, as I said, is to understand not just our own views and vision of gender and global health, but to engage much more widely with different stakeholder groups and different community groups across the world. So on the right-hand side of the slide, you'll see a fantastic piece of social network analysis based on Twitter handles, as far as I remember, which really indicates how we as commissioners talk to each other within the Twitter sphere and across social media, but also shows you the different kinds of communities that each individual commissioner also engages with. And so you'll see that whilst a lot of the commissioners are networked, many of the commissioners exist as very separate networks and bring those voices and those views and those visions into the work that the Commission is trying to do. And on the left-hand side of the slide, you'll see that we really, I like to think that we really did succeed in our original aim to be truly multidisciplinary and multi-sectoral in our approach. In other words, that we encompass a range of methodologies and subject areas as a group of commissioners. So we've had a fantastic set of seminars so far. We opened with Raewyn Connell talking about the epistemology of public health knowledge, being based predominantly in the paradigm of science-led, evidence-based research knowledge formation, a model that Raewyn very articulately reminded us fails to really capture the dynamics and the order of gender within and across societies. She also reminded us that this model of knowledge was created within a framework of colonialism, a system that she characterized as masculinized and that persists today and lies at the heart of some of the power inequalities we see between the global north and the global south today. And that was something that Pascal and Emma then picked up on in their seminar, reminding us that much of public health relies upon the disciplinary evidence of positivist science, but addressing gender inequalities and other inequities across society is not about taking a reductionist view of the size and scale of a problem, but understanding and addressing the deep-rooted structures and systems that perpetuate inequality. And part of this, as Pascal and Emma very clearly reminded us, involves coming to terms with the colonial nature of much of public health, again reflecting Raewyn's perspective as well. The work that Emma and Pascal presented us showed that much of the approach of decolonizing the global public health space is still situated in the stage of showing what the problem is rather than finding solutions to the problem. Decolonization provides an opportunity for a reversal of that and a space for a plurality of voices and visions. And I would say that if we replaced decolonization with gender in that sentence, that also speaks to what we're trying to do within this commission, that we're trying to move beyond the diagnosis of what the problem is and be an action-oriented, solutions-positive commission. We have very much heard from many of the commissioners about real-world examples of how communities themselves can challenge the ingrained systems of power that perpetuate, embed, and ingrain gender inequalities derived from historical inequalities as referenced by Raywin and Pascal and Emma, in order to really turn those inequalities on their head. Renu and Kathy, for example, drew on theories of community mobilization to address the broader social and structural inequalities. Sahaj in Gujarat, India, uses an SDG framework and a gender index to track progress at the level of the community. Community report cards can both monitor progress and hold systems to account, but it's not without its challenges, including the fact that the disenfranchised often cannot afford the costs of speaking out. Fran and her colleagues from Rwanda, a community-controlled organisation for Aboriginal women and their families in Australia, talked about the importance of understanding both theory and practice to catalyse change. At Rwanda, culture, one of 4 of Bourdieu's capitals, is the foundational aspect that underlies all of their work, directed towards Aboriginal ways of being, knowing and doing, seeking to decolonize the community. Seeking to decolonize means that the community has reclaimed space and power. Sorry. Elena, Gary and Morna have shown how taking a rigorous, empirical and intersectional approach to gender and health can reveal inequalities both between and within societies. Gary drew on the extensive work of the Lancet series published 2 years ago to highlight the evidence base, both of the strength of the gender health relationship and the impact of interventions that respond to gender inequalities across society. Elena provided a clear framework for thinking about gender in relation to a larger framework of inequalities across society, addressing, for example, race and class as well as gender. And Morna highlighted how taking an open mind to the empirical evidence can reveal unexpected findings. In this case, the relationship between HIV, treatment and outcomes, and how they differed between men and women in South Africa. A deeper dive into that empirical evidence found that men were actually dying from violence, road traffic accidents, and suicide. In other words, expanding our vision from the narrow issue in front of us, men and HIV, to look more holistically at the data, helped identify where future interventions should be situated. And finally, systems that work for everybody was the topic of the presentations, the seminars led by Sophia and Simone. Sophia outlined how a human rights-based framework can be used as a tool to both promote gender equality and health, particularly through a legal approach, although she pointed out that gender is frequently missing or inconsistent in the relevant global health treaties, treaty bodies, etc. This lack of legal clarity means governments can obfuscate their commitment. She urged us to listen to the priorities of communities themselves. Again, that recurring theme through many of the seminars, that this is not just about conversations held in academic or UN environments. This is about what communities and people on the ground actually think and want from gender equality and health equity. And that's exactly what Simone described in her talk, focusing on the medicalization of childbirth in Brazil. After outlining the horrifying impact of an approach to childbirth that focused more on the medical than the maternal, Simone highlighted the role of social movements in pushing for indicators that place women at the very core of what is being measured. I feel, sadly, we've actually lost a slide, which was the slide for that covered the work of Ben and Khadija, and I apologise profusely that slide seems to have disappeared from the slide deck. But both Ben and Khadija emphasise the importance of understanding the role of individual constructions of gender and how these interplay with the global norms and ideas of what gender equality should really look like. You can, of course, catch up with all of those seminars. They are available on a number of websites for the institutions involved in co-chairing the commission, so that is at the United Nations University for International Institute for Global Health in Kuala Lumpur, where my co-chair Pascal Alotti is based. You can find these seminar recordings at the UCL Centre for Gender and Global Health, where I'm based. And I'm not sure if my other co-chair, Asi El Haj, actually has a website, but I feel like that should probably be one of the activities of the Commission moving forward, that we have a web page for Asi as well, where you can also catch up with these seminar recordings. I'd encourage everybody to check out the past recordings, to look at the fantastic series of blogs that have been written based on the seminars. And those blogs have been pulled together by an incredibly competent team of young interns and young researchers. My final slide would be, if I could get there, just to remind you that this is not the end of the seminars themselves, but the seminars will now become part of a much larger program of engagement, dialogue and conversation, as we really try to push forward the boundaries of our understanding and our action on gender and global health. As a set of commissioners, we will continue in the background with all of the research, analysis, synthesis and writing that you'd expect in order to be able to produce a written report by the end of 2022. But for now, I'm going to finish here with just a recognition that it has been a very challenging but incredibly stimulating year. And to thank all of you for the seminars that you've joined, to encourage you to join future ones, and to, most importantly, to encourage you to now stay with us for the next half an hour as we move to the real business of today's seminar, which is the presentation from my great friend and colleague, Gary Barker, who will be talking to us about the incredible work that he's been involved with for the past 20 years at Promundo. So Gary, over to you. Thank you.
Thanks, Sarah. I think the slides should be up. Someone give me a thumb up that those are showing. Yeah, great. Thank you, Emma. First off, it's an honor to get to share and to reflect, particularly after so many inspiring and necessary presentations that have come before in this series. And I'm thrilled to get to share some reflections about masculinities in health. So both thinking about individual men, but also the structures and systems and norms that we call masculinities. And I wanted to dive specifically a little deeper into some experiments, and I'm calling them in attempted systems change. How can we take some of these ideas and make some evidence that they actually do change how the health systems work, how services are delivered, and in terms of outcomes in the lives of individuals? And let me see if I can get this now to click ahead for me. Sorry, I seem to be having there we go. Now I'm doing it. As Sarah mentioned, I work and I'm the co-founder of Promundo. We are an NGO working in this space from the angle of designing programs, advocacy, and also research. About half of what we do is research. We are 6 independent NGOs. I'm the head of the US office, but we all work in partnership, but independently without a headquarters model, to bring some thinking to engaging men and thinking about healthy masculinities and male allyship, and taking those into larger scale social institutions, school setting, workplaces, the health sector, and otherwise, trying to go beyond what a lot of the work does, which is important and necessary at the program level, but really to try to think about this intersection of gender and masculinities as we go into larger scale social institutions. I come into this work as a white male cisgender heterosexual man from the global north who's lived about 1/3 of his life in Brazil, where I did my dissertation work. I'm a developmental psychologist by training, with all of the deformities that brings of looking at how humans interact with our social environments, and particularly in my case, looking at how gender and masculinities shape who we are in the world. So I think it's important just to give that proviso of how I'm looking at the work. So what do we talk about? We talk about men's health, and Morna's presentation in the last session was extremely illustrative and important on this topic, but I thought it was important to bring up a few issues that I think are there, and they'll come out in the two case studies that I'm going to share. One is contestations. We have to acknowledge, and Morna brought this out in her presentation, that talking about men's health has come into a system where women's health and many other health both individuals and categories have had less attention than they deserve. So certainly talking about men's health, and Sarah's work with WHO and many other spaces has found just how challenging it is to even bring up the issue of men's health. Then there's complex relationships of power. Which men are we talking about? Which men have access to health services and which men don't? We've got to talk about where budgets get allocated. There are some issues like sports medicine or cardiovascular health in some parts of the world that are mostly men's health issues, depending on the country, that get a lot of the budget within limited public health budgets. There's some hospitals that I've worked with in some parts of the world where you can see the difference between an underfunded maternal health wing, and you come around the corner to the cardiovascular health unit, for example, and see where resources are allocated. So we've got to talk about within men's health, which aspects of men's health, which aspects of health and men get attention. We've talked a lot about social norms and making those visible, and particularly making norms around masculinity visible, but we also need to pay attention to other social determinants. Sometimes are bigger determinants of men's and women's health outcomes. There are corporate interests involved. Some of those have been quite obviously harmful, whether it's promoting certain kinds of alcohol use or smoking, or access of the way that corporations may act to harm communities and harm men's and women's health. But there's other instances where we can say that corporations have in fact contributed in areas where there hasn't been public sector funding, and I'll talk a little bit about that as well. Relational aspects of men's health often left out of this. The impact of men's health problems on their partners or families. We don't talk very much around how the 5 years average life lost or lower life expectancy of men affects families, particularly women who often pick up the pieces when men pass away earlier or have chronic health issues for many years before they pass. That issue seems to be lost. We continue to kind of do these buckets of men versus women without looking at how much our health issues and needs overlap and affect each other. And of course, sexualities, diversity, identities. As we talk about men's health, we have to make sure that we decenter a heteronormative approach. I provide a picture here of a couple of a household, a different kind of household, two fathers and an adopted daughter who were part of a campaign that we led in Brazil, so that we begin to think about family and identities and sexualities in a more diverse way. And then finally, a lot of this field about men's health has been at the level of health interventions or project logic applied to it, not nearly as much around health systems change. And I want to talk, the two examples I'm giving are particularly around that topic of systems change. I don't have to do a lot of this because Morna did this before, and I know Sarah has certainly published a lot on this, and other colleagues, part of the commission, have around what do we know globally, what kind of conclusions can we make about men's health. We did a review of the global burden of disease data. This is now 2.5 years ago, I believe. Not really anything new in there, but I think it is important to start with that conversation. We know that 50% of premature male death and 70% of male morbidity is attributable, at least in part, to 5 key health risk factors: diet, smoking, alcohol use, drug use, and occupational risk. We looked a lot at how masculine norms affect that, but I think it's equally important to talk about the structural factors that determine that. Diet, of course, a lot based on income and where you live. Are you in a food desert, or can you afford a healthier diet? Smoking and alcohol, of course, both which family you're born into, settings you're born into, how much marketing campaigns target your demographic for that and how much they don't. Substance use, similar dynamics at play, occupational risk as well. We often kind of distill that down to a behavioral risk, but it really is a situational and a structural risk as much as it is, did you wear your hard hat? Did you have access to a hard hat? Did you have a job? Did your job require you to wear a hard hat? All those kinds of things, I think, as we look at these factors, we need to take into account. There's just some of the numbers to look at. The percentage of mortality and morbidity we can attribute to men's health. specifically across these issues. And I'll call your attention to the bottom. Just we brought in the 6th one, which is unsafe sex, far lower than many of the others. And I think that touches on what Morna brought in before. A lot of our first understandings of men's health or deeper research on the topic, particularly in the global South space, came out of HIV work, including Promundo. A lot of our initial work in Brazil was around men and HIV, but really we had to look further up this scale. And I'm not even including in here some of the other external causes. So traffic accidents, suicide, homicide in the list as well. So just to give a sense of kind of how the data also blinds us to certain aspects. We tried to find any evidence around men's health-seeking behavior, whether anything could be found in the global burden of disease, and we don't really count that in the global burden of disease. So we talk a lot about men's low health-seeking behaviors, but in terms of data, it is still something we need to gather more around. Here's just a slide showing as well men's the ratio that men face early mortality or higher rates of morbidity due to these health factors. And you can see some of them are quite close. Diet, nutrition, quite high for women as well, or similar in terms of what it means for women's health. Others, quite big disparities, alcohol use being the largest of those. And then others, unsafe sex, where women face higher disparities compared to men. So just to give a quick glance, as I said, I know this is a very, very quick overview of thinking about men's health. A bit about norms. We've spent a lot of time as an organization, and certainly other members of the commission. Gary Darnstedt talked about some of the work on the Lancet series on gender norms. There's a lot of data out there. We've been gathering some of it through our International Men and Gender Equality Survey, and then more recently as well with a survey called the Man Box scale that we developed and have tested in a number of countries, the UK, US, Mexico, Jamaica, Australia, and some other countries. Lots of representative data with men at different ages, finding that, and particularly with 2 scales that we've developed, the Gender Equitable Men Scale, which Ravi Verma has also been a part of, and others, and the Man Box Scale, which colleagues at the University of Pittsburgh have been part of helping us develop. Psychometrically evaluated attitude scales that hold up consistently. The more you are into the masculinist views in terms of your self-reported attitudes, we can find huge associations with health outcomes and other outcomes. Use of violence, participation in unpaid care work at home, participation as a man in maternal and child health care issues with your partner, couple communication about reproductive health, having sought HIV testing, having paid for sex, self-reported STI symptoms, condom use, substance use, traffic accidents, bullying, suicide ideation, depressive symptoms, and that list goes on. When we do multivariate or bivariate associations with these norms, with these attitudes and a number of health outcomes, they hold up in robust ways. And I say but because I think it's important that when we also have to look that on some of these issues, there are other factors that come out as more important. Your household of origin, gender dynamics in the household of origin, poverty, educational attainment. Many of these associations with the norms hold up even in that multivariate analysis, but they're often not the most important ones. And we've been guilty of trying to make a lot of attention to the fact that these norms exist. Masculinity does do in terms of being normative based, among other things, do have a direct impact on health, but they're never the only issues. There is a whole field of practice that's come out of this norms-focused approach. We've been part of that, as have some other commissioners, in terms of building health-based interventions. And in rigorous impact evaluation, we've got outcomes that have been shown in sexual and reproductive health behavior, HIV specific. There's a lot of work in violence prevention where we've been able to show changes in both in women's reports of experiencing violence as well as men's reports of perpetration. A lot of behavioral intentions that we've been able to measure. Ravi's been one of our leading scientists in this space, and we continue to build this space of what we often call gender transformative approaches. Most of this impact evidence, and I think it's important to affirm that, comes either from group education or from community mobilization, sometimes both of those together. So we really are talking a kind of narrow set of what we are calling interventions in the health. There is newer research in apps and online spaces, and we'll kind of watch this space to see what we learn from those kinds of interventions, even more important in this COVID online world that we're living in. And when we've looked at rigorous reviews of rigorous evidence, which themselves already skew which evidence we look at, of course, there's been a lot of reviews. We've done a couple of them. There's a couple of them that I've posted there on the slide of some recent ones. Typically, when we've done, let's look at those that show up in peer-reviewed journals that have rigorous designs. About greater than a third of them do show that there is some impact in behavioral or attitude change. So we do have a reasonably good science that gender transformative approaches in health that engage men can produce results. So that intervention logic is giving us some input for changing men's individual outcomes, attitudinal behavior, and sometimes we've measured impact in terms of other members of the household, female partners, children. But there's a lot less research, and that's where I'm going to step into now, around health systems change and approaches there. There's a lot of discussion of scaling up of effective models, but not a lot of discussion of how we scale those in to health systems. So I want to talk about two in I believe I've got about 15 minutes. I want to talk about two case studies that we've been, as an organization, involved in. The Rwanda, much more co-authors of and co-drivers of, and the Brazil one, we've been a partner and an activist and sometimes a troublemaker together with Brazil's Ministry of Health. I'm going to start with Brazil. Quick snapshot of men's health. Just a few data points that I picked. 17% of men report an alcohol abuse or substance dependency in Brazil. There's a 7-year life expectancy gap between women and men in Brazil. That's higher than the global average. Brazil's demographic pyramid shows a gap of about 4.7 million men. That is, there are 4.7 million fewer men than women in Brazil. Brazil's population of 14 million last time I looked. So just to give a sense of the main reasons for that in Brazil: homicide, traffic accidents at the top of that in terms of causes of men's early mortality. The fourth item there shows that homicide focus is, well, the overwhelming victims are men of color in Brazil, so men of African descent. They represent about 49,000 homicide deaths per year. Brazil has one of the highest per capita as well as homicide numbers per year. And then some other data just about mental health, just to give you a very quick snapshot of health in Brazil, of men's health in Brazil. Brazil created its Ministry of Health, created in 2009, what it calls the National Men's Health Program. It's one of, I believe, the last count, and I think Morna mentioned this as well, I think about 6 countries that have some kind of national men's health program connected to the Ministry of Health. Brazil is one of the few global South countries that has this. It came out of and was born out of a lot of activism from some of us, including Promundo and many other NGOs. It was in a lot of dialogue with women's rights and women health partners, and particularly lots of conversation to make sure it was not taking away or didn't take away attention from the fragile gains made in terms of women's health. It had to, by necessity, be low cost. It was not given a big budget. Its intention was not to have a big budget, but to speak to the diversity of Brazilian men. Second was to link it to other health goals within the Ministry of Health. So specific linkages to sexual and reproductive health, to maternal and child health, to HIV prevention and treatment, to violence prevention, and other topics. So it really had to rely on resources that go through those health sector areas, including women's health and family health, rather than having some big budget on its own. After a first attempt, when I say a first attempt, its first head or director was a urologist, and you can imagine the parts of the body that the first attempt at rolling out the program looked at. Fortunately, the next direction that came on focused on men's health in a much more holistic way, and it involved doing what we do in social science, which is to say, where are men? And so it started with the question of where can we find men in the public health system? We were part of that research. And we found that probably the modal point of men's contact with the primary healthcare system was accompanying a partner to a prenatal visit. Now, it was not that he was in the clinic there. It was often that he was in the waiting room, or even more common, that he was in the parking lot, or that he may have dropped her off. So we began to use that and discuss with the health system about how to use that as the point of entry. If that's where men are, let's go to the point of least resistance. And the other thing to build on was looking at the health providers themselves. Where did they get information? How do you make changes in the system And it was decided to focus on online training, which Brazil's been a pioneer in many years before all of us were stuck in this online life that we're in now. So a lot of time was spent developing a prenatal health protocol for men. Step one is when a woman came into the public system, she tested positive for pregnancy, affirmed she wanted to have the child. She was screened for violence from her male partner, asked if she wanted to include him in the consultation process. If she did, and the locus of decision on her, with her, he was invited to a follow-up visit. He's invited to the consultation room. Some of that involves some really sophisticated high-tech stuff like having a chair for him to sit in, instructing the nurse or the provider to actually ask him his name, to maybe look in his eyes now and then, and to invite him, basically an opt-out approach where the provider would also say, I've got these 3 options for you to come to a visit for your own preventive care next week. Which of the options would you like? So rather than asking him, does he want to come? Very deliberately is to say, we've got these options open for you next week. When would you like to come? He's invited for his consultation. We don't have really good data on how many men show up for that. There's data on what happens when they show up there. STI and HIV testing, one of the key ones. General prevention visit, blood work, update on immunizations, and if he needs it, referrals within the system for secondary care. He is also invited in subsequent prenatal visits to be part of birth preparation planning. And then this is also linked to men being present at birth with all of the challenges that you heard Simone talk about in her presentation. And then in a few municipalities, there is parent and father education sessions, although not many. And we've been part of testing those. It is really tough to get men to come to such sessions. So we've done less investment in those over the years in Brazil. Rwanda, by contrast, those work quite well, and I'll come back to that. What can we say as some results? One, there's not great data. There have been a couple of surveys, but there is not great impact data. So I'm citing what's out there. It's been a 2017 national survey that 75% of women who had recently had children said their male partner was present in one or more visits. Present this time, meaning he was in the consultation room. We don't have good pre-test or pre-moment data, but that does seem to be quite an increase from what we saw in the past. 2/3 of women said their male partner in 2017, women who had given birth in 2017, said the male partner was present at birth. We do think that is quite an increase as well. There was a 2012 survey in Brazil that found that 16% of women who had given birth in the last year had a male partner present at birth. Those numbers, we don't know if the sampling frameworks are quite the same but we do think that does suggest a tremendous increase. 82,000 health professionals have registered for the online course on men's health. We are the co-authors of that course. Again, we don't know what kind of outcome, but that is encouraging. I hope that doesn't mean they just registered and went to one session. We don't have great data, but again, that's a good indicator to start. The men's prenatal visit is now the single largest path to men's participation in primary healthcare centers in Brazil. So that is something to say of its scale. Again, there's a lot of need to dig in more into impact evaluation data on it. Challenges and reflections, and I'm going quickly because I want to get to Rwanda finally. There's limited attention in the system to other health issues that are as important. Suicide, traffic accidents, mental health, violence. Certainly the referral to secondary care is one place into mental health services, but these other bigger in terms of men's mortality in Brazil are kind of, they're there in fairly symbolic or kind of messages, but not really anything in the health systems that shifted. And in terms of which men are there, clearly because it's a focus so much not only on the prenatal visit, but there's been less around younger men and boys, around elderly men, around gay and non-binary men. There has certainly been a lot of attention in the HIV sector for men who have sex with men, but there's a lot of gaps in terms of who's getting coverage in this national program. And then everything that you heard Simone talk about in the Brazilian health system, and including a right-wing political effort at the moment to undermine it and to defund it. The men's health program suffers from those same issues. It has a very small budget to start with, so its budget hasn't really been cut because it is so small. But I share some of those successes, but say it is along with Brazil's public health system, it is in a quite precarious moment. Shift continents at the moment. I know this is a lot to try to pack in. I want to try to provide some reflections on Rwanda and then move to some concluding comments and open for some questions. We've been partnering particularly with the NGO ROMREC, the Rwanda Men's Resource Center, since about 2009, 9 and 10, working on a parent training module, and particularly a father-inclusive parent training module, and then looking at taking that into the Ministry of Health through the maternal and child healthcare system in Rwanda. The work had been to build very much on men's existing belief that they should be involved in the lives of their children, so building on a positive norm that was there in the face of lots of negative and unequal norms, but looking at fatherhood as an entry for men around reproductive health, maternal and child health, preventing violence both by men against women as well as against children, engaging men more equitably in caregiving, and trying to promote overall more healthier couple relationships. We designed an intervention called Bande Brejo. It comes out of our program P module, P for Paternidades and Paternidad, our fatherhood training module that's been used in about 15 different countries. It's a 17-session structured curriculum with activities around gender norms, equipping parents with parenting health, relationship skills, somewhat like the Parenting for Lifelong Health that WHO and others had developed, encourages couple communication, trying to do all this within a framework of gender equality. And that picture there that you see with the man with his hand over the woman's shoulder, that we want that hand to be supportive, not a controlling arm. So very much within a feminist and a women's rights framework as well. Not that don't want to go into detail of the whole timeline here, but we've done testing of the curriculum. And then in 2015-16, stepped into a randomized control trial. I do just want to call attention to how many years of investment this is required to do. Part of that is to build the relationship with Rwanda's Ministry of Health. They are co-owners of this process, and also to take the time so that it is grounded in the community setting. It is responding to the real life situations and not a model coming to fix the problem, but doing this and building this together with Rwandan colleagues who are the leaders of this process. The randomized controlled trial was about 1,200 couples, randomized at the community level. Here's some of the results that we've had. We've published on this. There's a link at the bottom of that slide that I can share. Reductions in violence, men's use of violence against female partners reported by women. So those are women's reports compared to the control group. Reductions in parental violence against children, greater participation by men in prenatal visits and support of and use of contraceptives, less dominance by men of decision-making at the household level, greater couple communication reported by men and women, and greater time use by men in terms of tasks, unpaid household tasks at home. We're now doing some data gathering around child outcomes. So we're looking at child development and child health outcomes that will have some data in a couple of years. These results held up 2 years later, and in a subsequent round of data collection that we did during COVID, where they held up when the rest of the country was experiencing a spike in men's violence against women, the rates actually continued to decline, even though there had been no further intervention with the intervention group. So we're going to scale with this now in partnership with the Ministry of Health to increase the reach and the sustainability. And we're now in the crucial phase of handing it over from NGO implemented, so it was facilitators trained and led by ROMREC and by us, handing it over to the community health worker system that Rwanda's Ministry of Health has set up. So the driver's seat and the controls to this whole process now pass to the Ministry of Health. We're testing first at the district level, and then we'll go to the provincial level of whether community health workers can carry out the model with the same fidelity. If the same outcomes can be achieved, there's some of the funders doing it, to move toward whether in fact it is scalable and sustainable. If you saw NGOs t-shirts showing up in the first photos, now these are the jackets of the community health workers, the vast majority women. We're also trying to recruit some men in that process who are in fact, they work with the Ministry of Health. So we're in this big handover phase at the moment to see if we can go from scaling up to scaling in. I'm gonna move a little bit to some final reflections looking at time. So I'm gonna skip ahead on this slide to talk about what next. And I wanna make sure we've got a few minutes for questions. So I gave 2 examples from the Global South of trying to build men's health, both of them, tellingly are within maternal in focus, because we've got good systems set up, reasonably good systems. I don't want to say strong all around the world, because there was political will to do it there, because there were at least some resources in that space that we could operate. We are still bringing a lot of blind spots to other men's health issues. Where do I think we need to look next? One, those other men's health issues. Certainly in the last few years, we've seen a lot of attention to men's mental health. I think we will want to see what kind of evidence begins to come from that. Most of that's been in the global north, UK, US, Australia, a few other settings. I think that's an area to pay attention to. I think we've still got to say that as we've talked about men's health, which men and questions of access, equity, structural determinants are still often kind of thought of at the end of our interventions rather than at the beginning. I think we've got some questions about the participation of corporate sector involvement. We've got to call out the harm where corporate sector has been part of causing harm, particularly in those issues I mentioned at the beginning on alcohol use, smoking, and nutrition, but also call them in. There have been moments where we've partnered with the corporate sector and I think been able to bring some new data and new approaches to the table because they've been some of the only resources available to do this. I think we have very few examples still of a relational perspective of men's health. How men's health affects partners, families, communities is still missing, I think, is kind of a missing place there. And the whole health system capacity, as we've rolled out our program-focused approach, I think we've not thought nearly enough about health system capacity. Both of the examples I just shared have been 10, 12 years in the making. It is a true challenge to get funders to want to stick with us for 10 to 12 years of a process when they come and say, show us in a 2-year log frame that you can resolve this structural health issue. I think we've got to push with funders as well to acknowledge how long it takes to do the data, the relationship building, the testing of approaches, and then to try to build it into health systems and see if it sticks. Take us a long time. And I think in this particular moment, and I'll end on that, we've got to look at the challenges of what, and I say this from the perspective of my two home countries of the US and Brazil, of how much we've got this combined deliberate misinformation about COVID, much of that very masculinist in its focus in terms of COVID deniers, and how much those have influenced public health policies and how much those overlap with other harmful and anti-gender equality agenda conversations. So I think that is something we have to hold up as well. I want to stop there so we've got time for comments. And look forward to continuing the dialogue on this.
Gary, as ever, every time I hear the work of Promundo, I am completely blown away. So many, many thanks for sharing that with us. It's just an extraordinary body of work that you've been involved with. I'm going to take Chair's prerogative, even though I can see that there are a couple of quick questions, but I just want to actually segue in from where you ended up talking about COVID and the public health responses to COVID. And I wonder, in an ideal world, a utopian universe perhaps, the lessons learned from all of those years of work, looking at norms and structures and systems and relations and masculinities and femininities, had any of that been taken into account in the COVID response? I'm not going to pick on Brazil because I realize that's an outlier as far as the COVID response is concerned. But had any of that been taken into account in any other country? How different would the public health interventions have looked, do you think?
Oh, yeah, the question of the hour. I mean, yes, I do hear at least the words being applied more. So discussions about an intersectional approach to looking at the impact of COVID, and certainly, Sarah, a lot of the things that you all have put online have called attention to that. We, as part of our recent State of the World's Fathers report that we do every 2 years about men's caregiving, we looked at the reviews that UNDP and UN Women have done on the social responses to COVID, the some 3,000 plus policies that they had looked at in terms of the COVID response. There was certainly in that review of policies very little evidence that there was a gender lens applied to that. And gender lens mostly meaning had we looked at how COVID was differentially affecting women. Perhaps the strongest gender lens applied in COVID social response has been social protection or cash transfer programs focusing on women. So, I think what would they look like? How different would it be? I think both in terms of how we're figuring out slowly in the US, how to talk to communities about vaccines, about moving away from shaming to actually listening to community concerns. I think we would be looking at messaging that talks about, without saying those words, perhaps around healthy masculinities. The UK, in fact, did convene a kind of an interest group discussion about that, of looking at health interventions with young men, noticing that young men were the least likely to be following COVID-related measures. I don't know if that turned into any actually changes in practice or any of the government's campaigns, but certainly we would have seen, I think, some different kinds of campaigns. I think we're starting to see some of that in the US with the desperation of the Biden administration taking over, of seeing these huge gaps. And it's, it's not by chance that we see the places where vaccination rates are lowest, or also those places where white men, and particularly white men with less than university education, voted at rates of 70 or 80% for the Trump administration. So there's something about how do we talk to communities where very masculinist and white masculinist norms are quite prevalent. And also to look at those communities as places that are often resource poor, that also have high rates of unemployment. These are some rural parts of the country who have not had the same kind of income and access to services as urban areas do. So it does make it, I think there is no easy answer, but I do think at least asking that question would get us to better responses.
I agree, Gary. Thank you. So there's a couple of questions that I'm going to start with the broadest question, which is: do you think that men that work on men's health must always be explicitly gender transformative?
Yeah, good question. I mean, we have taken that up as a kind of a call of desperation, which is to say, please pay attention to gender. And Sarah, your career has been in this as well. I think there is, I actually think, maybe this is my thinking, and I don't want to speak on behalf of all of my Promundo colleagues in this or partners along the way, is that we sometimes have made a lot of noise on that. And sometimes I think if we get to the business of changing systems, let the norms worry about themselves at times. I do think there's a lot of this work, if we can get men in certain places so that the system does some of the things that it does well, we can worry about the norms, next month, next year. So I do think there's a lot of basic troubling questioning of public health systems and the spaces where they already work reasonably well, and the spaces where men may be showing up, that they don't have to have passed kind of, everything we would want them to be defined as a pro-feminist man or a feminist ally. I do think we can get to some good outcomes and hold them accountable. We're not giving up on that cause by any means. But to say, first, I want to get you in the door for some basic health stuff. And over here on the side, we're going to keep pushing and believe that the push from the women's rights space, from our feminist allies, will continue to hold you accountable. But I want to call you into the system, and we'll call you out for the harm over here at the same time. But I do think that's a good question, again, to say, maybe we can be slightly less precious that every time they've got to be gender transformative.
Indeed, Gary, there's a number of questions, and I think we might have to come back to some of these later, but I just have a very specific question to end on, and it was about it's a question from about the intervention in Rwanda. Did it have an impact on family planning, such as birth spacing?
We don't have that demographic data, but what we do have is reports of higher contraceptive use and greater participation by men in that decision, and intentions to do greater spacing. We hope at the 5 and 6 year mark to begin to be able to compare actually how many children, how many births were there in pregnancies from the first wave of data collection. So what we have as good news on this is Rwanda is a very special case of being able to continue to find people. So the 1,200 couples that we're following up, we have very low dropout rates in terms of being able to find folks. and being able to follow up on that. So some of those about actually ways of decline. I just wanted to acknowledge, I loved Jessica's question. Who is the health system working for? If it's not working well for women and not working well for, and I think we have to get our which men, which women, which health industries, because there are pockets of good that we're talking about. And I think it is important that we get really, I don't know if the word is granular, but we do need to talk about some of the outcomes that we're talking about. We have some reasonably good outcomes in some countries. But to say that maternal health is working well in a few countries or aspects of maternal health doesn't mean that we've treated women in the wholeness of their health. And to say that, some prostate cancer screening is going well in some countries doesn't mean that we've gotten men in our full embodiment in terms of health. And we have to ask the which men and which women. So again, I think that drives us to say that even, these clusters of men's health and women's health are really, they're too big to be that meaningful unless we get to that level of connection. I mean, I guess granularity of who we're talking about.
I absolutely agree, Gary. And just in terms, as a final, this is a request actually to Emma and Anna. Perhaps in the chat under the video, we could actually put in the links to Promundo's work, because you've got such a huge volume of work and evidence and discussion in this space, addressing many of the questions that have been raised. If those links could go in under the chat or under the video, that would be great. And it just remains to me to thank you again, Gary, to apologize for taking up some of your seminar time. Thank you to everybody for sticking with us for so much longer today, and to say that the next seminar will happen next week. And for those of you that are tuning in regularly to our seminar whilst they're coming out live, please do note that next week's seminar is actually coming an hour earlier than the usual time. But thank you again, Gary.
Thank you.